a PhD, and we were very fortunate to have Kyla do her PhD in our laboratory, and then she was very sought after upon completion of her PhD, and she chose to do her postdoc down at Wake Forest in Salem, North Carolina, and there she was promoted to an assistant professor. And during this time, Kyla had kept in touch with us. She initiated a lot of collaborations between our lab and her group team in Wake Forest, and we're really fortunate that Kyla has decided to come back to Tufts and to continue some of her great work. So without further ado, I would like to have Kyla present on her current work, which is funded by the NIH, on nutritional risk factors for osteoarthritis and related disability. Thank you.
Thanks, Sarah, and thank you for inviting me to give this talk today. I will screw up this clicker at some point, so I'm going to apologize in advance. Arthritis refers to a group of diseases or conditions that are characterized by pain, stiffness, and impaired function that result from joint inflammation. If you're Greek, the word arthritis actually means joint inflammation. It's quite common. It affects, in almost every state, 20% of adults. In some states, it's actually up to a third. It affects women more than men, and it also, the prevalence increases with age. So if you're a woman, say around 65, you have a 50-50 chance of having arthritis. If you're a woman around, say, 75, more likely than not, you have arthritis. The prevalence is expected to increase. In some states, by 2030, it's actually projected to double, increase by at least 50% in several others. And this is driven primarily by age and obesity being very strong risk factors. Arthritis is the leading cause of disability among adults in the United States. Almost 9 million adults report having some disability related to arthritis, which is actually more than heart disease, diabetes, and stroke combined. There is more than one form of arthritis, but by far the most common form is osteoarthritis, which is going to be the type that I'm going to be talking about for the rest of my talk. Osteoarthritis itself is a leading cause of disability, and what this is showing is the percent of disability that it's attributable to different musculoskeletal conditions. Osteoarthritis is shown in red, and there are more adults with osteoarthritis or OA that report disability in terms of walking, lifting, changing positions, and that means like getting up out of a chair, and other daily living tasks than most other musculoskeletal conditions. The burden is high in terms of healthcare utilization and cost. So what this is showing, these are data from the Medicare beneficiary survey, so these are older adults. I think the mean age was 75. But it's comparing the healthcare utilization in terms of doctor visits and healthcare but not MD visits per year between older adults that don't have arthritis and older adults that have knee OA specifically. And over the course of a year, older adults with knee OA visit the doctor 6 times more than those who don't have OA, and they visit non-MD healthcare professionals 4 times a year more. So the annual cost of that is high. It's estimated to be over $115 billion direct and $12 billion indirect, and that's 2013 dollars. So if you think about this in combination with the graph I showed before, how the prevalence is expected to increase, this is going to increase. So what is osteoarthritis? Osteoarthritis is characterized by pathological changes in all the joint tissues. So this is a cartoon of a knee. Osteoarthritis can affect basically any joint, but the knee is by far the most commonly affected. The next two, I think, are hip and hand. But on the left here, you have a cartoon of a normal knee. So this is the femur, this is the tibia, and there's nice smooth cartilage, and this is a kneecap, and it's nice, and it's not swollen, and everything's good. In osteoarthritis, what happens is the cartilage can degenerate, become fibrillated, and at end stage it can actually wear away, so you end up with bone-on-bone contact in the joint. There are changes to the bone underneath the cartilage, so it can develop what are called osteophytes, which are these kind of bony protrusions where you shouldn't have bone. The bone can become sclerotic and develop cysts. The synovium, which is the area under the kneecap here, can become inflamed and swollen. And the other tissues that are affected by OA that are not shown here are the meniscus, which can become damaged, tendons, and ligaments. Importantly, there are currently no known therapeutics that stop this or can reduce this once it starts. So there are several nutritional factors that have been implicated in joint health, and I've listed several here. I'm going to talk about a few today. Weight loss has probably been studied most extensively and is beneficial. The others have been studied to some extent, but with inconsistent results at this point. I'll talk a little bit about weight loss and glucosamine, but the majority of my talk will focus on vitamin K and vitamin D. So this is just one study that looked at the effect of weight loss on knee OA symptoms in older adults. It was a randomized trial. It was 4 groups, 18 months long, and there was a diet group, an exercise group, a group that got diet and exercise, and then there was a healthy lifestyle control. The exercise consisted of 3 hours per week. That was 30 minutes of walking plus 15 minutes of lower extremity resistance training and then a cool down. The diet intervention was targeted at 5% weight loss, and it was primarily behavior-based, so it was weekly counseling to start, and then it transitioned to biweekly and monthly. For the last, I think, year, it was a 1-month kind of behavior-based intervention just for them to maintain weight loss. And then the healthy lifestyle were invited to attend monthly seminars on different health-related topics. So it was an active control group, but they didn't get specific intervention. What this is showing is the improvement in function. So WOMAC is a standardized questionnaire that assesses joint function and pain and stiffness, and it's used commonly in studies of osteoarthritis. Higher scores are worse. So you can see over the course of at least the first 6 months, there were significant improvements in function in the diet and the diet plus exercise group, and those were sustained over 18 months. There was some improvement in the exercise-only group, and also the healthy lifestyle did improve, but not to the extent that the diet and exercise group did. So in this study is showing the benefits of diet and exercise in improving function, and there were similar results that looked at pain, and the improvements in pain were comparable. So glucosamine and chondroitin. So this is something that we've probably all heard of. There was, I think, ads on TV for it all the time. If you don't take it, your dog might take it. But glucosamine and chondroitin are proteoglycans that provide the structure and also resiliency to cartilage. And there were several studies that came out in the early 2000s, primarily from Europe, that showed benefit of glucosamine and chondroitin in terms of pain, function, and also improving the structure of cartilage. The NIH funded a multi-site trial that compared the effects of glucosamine alone, chondroitin sulfate, the combination of the two, celecoxib, which is a COX-2 inhibitor, and placebo. The first part of this study, the main study, was 6 months. And their main outcome, this might be a little hard to see, but they were looking for a 20% improvement in the WOMAC pain score. Overall, there was no effect of any treatment compared to placebo. When they looked at patients that had moderate to severe pain at baseline, there was some improvement in the group that received the glucosamine and chondroitin, but they interpreted these findings cautiously on account of multiple testing. Now you might say that 24 weeks, 6 months might not be enough. So in a subgroup of this study, they extended it out to 2 years. And this is an interesting way to present the data. But they combined the function and pain scores. And you can see here that all the groups, including the placebo, had improvements over the 2-year study. No beneficial effect of any treatment. And they actually looked at some of the structural outcomes and didn't see any benefit of glucosamine or chondroitin or both on the structural outcomes either. I don't know if this has really impacted the glucosamine and chondroitin supplement industry, but it is what it is. So for the next few minutes, I'm going to talk about what's been done with vitamin D and osteoarthritis, and why would vitamin D be involved in OA? Well, OA involves changes in subchondral bone, and vitamin D's role in bone is fairly well known. Chondrocytes, which are the cells that produce and maintain cartilage, express the vitamin D receptor. And the active form of vitamin D has been shown in vitro to suppress the production of inflammatory cytokines and cytokines that can degrade cartilage. So there have been several observational studies that have looked at the association between vitamin D status and knee OA. I've listed some here. Most of them measured vitamin D status using blood levels. Some of them it was intake. Generally, most of the studies report a positive association, higher vitamin D, less OA, better pain, better function. And there was a systematic review that was published in 2013 that concluded there was strong evidence of an association between vitamin D and cartilage loss. So what about the randomized trials? So there are 2 that have been published to date. One was done here that was published last year, and this was by Tim McElendon's group next door. And they randomized 146 older adults with symptomatic knee OA to receive 2,000 IUs of vitamin D3 or a placebo for 2 years. The dose was titrated, so they wanted to get everybody up to at least 36 nanograms per mil. So some of the participants, they had to increase this dose to get them to this level. Some of them were not able to get to this level. I think 60% achieved 36 nanograms per mil. Be that as it may, the average in the intervention group at the end of the study was almost 39 nanograms per mil versus 25 in the control or placebo group. Their 2 main outcomes were pain, and then they looked at some structural changes. So this is the change in the pain, the WOMAC pain score over 24 months, and you can see there was no effect of vitamin D. When they looked at the structural outcomes, so you can look at the structural outcomes on MRI or X-ray. MRIs are more sensitive to the structural changes. So they compared the cartilage volume between the vitamin D supplemented group and the placebo group. And at the end of the study, there was no difference between the 2. Later that year, there was a study that came out. This was done in India. It was a small study, just over 100 adults, mean age 53. And they enrolled people who had a vitamin D level less than or equal to 20 nanograms per mil. Their intervention consisted of a 60,000 IUs of vitamin D3 for 10 days, and then one every month for a year. And the placebo regimen was the same time. At the end of the study, the intervention group's vitamin D was just over 36 and almost 16 in the control group, so this group was still considered deficient. And they reported significant improvements in pain and function in the group that received the vitamin D. So this could suggest that vitamin D is more beneficial to people who are deficient, because this trial enrolled deficient people, but it definitely needs to be replicated. So I'm going to spend the rest of my time talking about why and how vitamin K is related to OA. When I left here in 2008, I thought my vitamin K days were over, but I say it's stuck to me, it's paying the bills, and it's working well, so I'm happy to present you some interesting data. So vitamin K is a fat-soluble vitamin. It's primarily found in green leafy vegetables and vegetable oils. Its primary function is as an enzymatic cofactor in the carboxylation of vitamin K-dependent proteins, which is showed in this cartoon using osteocalcin as a representative vitamin K-dependent protein. It's found primarily in bone. In the presence of vitamin K, the glutamic acid residues are carboxylated, and it's this step that confers function to the protein. So when the glutamic acid residues are carboxylated, the protein is able to bind calcium. In the absence of vitamin K, or in the presence of warfarin, the vitamin K-dependent proteins are less functional. So the most common vitamin K-dependent proteins are clotting proteins. But as you can see here, there are several other vitamin K-dependent proteins. Most relevant to this talk are the ones found in cartilage and bone. I've listed a few, including matrix GLA protein, which functions as a calcification inhibitor, GLA-rich protein, osteocalcin. A lot of these proteins, their function isn't known yet, but they are present in cartilage, and also several in bone. So matrix GLA protein is probably the most studied vitamin K-dependent protein in cartilage. It functions as a calcification inhibitor, and these are images from matrix GLA protein or MGP knockout mice compared to wild type. The top two are stained with von Casa, so they're staining mineral, and the bottom two images are H&E stain. So you can see in the MGP knockout mice, there's a lot more mineral. The mineral stains black than in the wild type. You could see here in the wild type mice, the chondrocytes are columnar. This is growth plate cartilage, and you can see the nuclei quite well. So this is healthy growth plate cartilage, whereas in the knockout mice, the cells are disorganized, non-proliferative, and less functional. So there's evidence that the carboxylation of matrix GLA protein is relevant to OA. So this was an experiment that was done by Richard Loser, who is someone I worked fairly closely with at Wake Forest, has some experience in vitamin K-dependent proteins and cartilage. And he, in his group, isolated chondrocytes, which are the cells that synthesize cartilage, and looked at for the difference in the carboxylation of MGP in normal cartilage and cartilage that came from donors with osteoarthritis. So you can see here in normal cartilage, the majority of matrix GLA protein is carboxylated, which is the functional form of the protein. Whereas in osteoarthritis, the majority of matrix GLA protein is uncarboxylated or less functional. So there have been a few observational epidemiological studies that have looked at the relationship between vitamin K nutritional status in OA. These are data from the Framingham offspring, and they looked at the relationship between plasma phyloquinone, which is vitamin K1, which is the primary dietary form in our diets, and the prevalence of hand and knee OA. So you can see that those in the lowest tertile of plasma phyloquinone had higher prevalence of hand OA, and then they also look specifically at osteophytes in the hand and joint space narrowing, which is a way to look at cartilage loss from x-rays. And you can see significant inverse relationships. So those that had lower vitamin K had more OA. Similar relationships were seen in the knee, but the statistical significance was lost primarily because you have more joints in your hand and you only have 2 knees. So they also did a spline analysis, a regression analysis, to try to understand what level or concentration of plasma phyloquinone above which there would be no more further benefit with respect to OA. There's no clinically defined sufficiency or insufficiency level for plasma phyloquinone. So based on their data, they proposed that that level was 1 nanomole per liter, which corresponds to the concentrations that are achieved when adequate intakes are met. So these are data in postmenopausal women, and the recommended intake in women is 90 micrograms per liter, micrograms per day. And you can see with 90 micrograms generally achieve a concentration of about 1 nanomole per liter. So low plasma phyloquinone has also been associated with a higher incidence of knee-OA. These are data from the MOST study, which is an osteoarthritis cohort. And depending on how they analyze the data, either knee-based or person-based, low plasma phyloquinone was associated with a 33% to up to 2-fold increased risk for incident knee-OA. So basically what I've just told you is basically what has been studied in terms of vitamin K and OA. So when I was at Wake Forest, I worked with Steve Krzyzewski quite closely, and he is a PI on the Health ABC cohort, which is a cohort of older adults. And we were able to get funding to look at the relationship between vitamin K status, and we wanted to see if what tissues in the joint vitamin K might be most relevant to. So they have MRIs of their participants, so we were able to look more closely at the different features or structural characteristics of knee-OA. So just very, very briefly, Health ABC, the cohort began in 1997. It recruited just over 3,000 healthy older adults that were between 70 and 79 years old. And when I say healthy, they were able to walk either a quarter of a mile or climb 10 stairs without rest. They were recruited from two clinical centers, one in Pittsburgh and one in Tennessee. So Tennessee, Memphis is in the western part of the state, and Pittsburgh in the western part of Pennsylvania. So there was a sub-study of Health ABC that looked at knee OA and through MRI. So it, enrolled 640 participants who had qualifying knee pain based on this criteria here, and just over 500 randomly chosen without knee pain. And they had knee MRIs between 1998 and 2000. And then they had follow-up knee MRIs in 437 knee pain cases and just about 140 controls about 2.5 years later. So we were interested in the relationship between vitamin K status and knee OA progression. So in Health ABC, there were knee MRIs that were, the knee MRIs are scored semi-quantitatively, and they're more sensitive than x-rays, so you can actually analyze the different characteristics or features of knee OA. For example, cartilage damage or loss is scored on a scale of 0 to 6 in up to 14 anatomical subregions. We define progression as a score increase of at least 1 in any subregion. So the distribution of plasma, this is phyloquinone. In Health ABC, the median was about 0.8 nanomoles per liter, and then we had about 8% or so who had concentrations less than 0.2, which was the lower limit of detection for this assay using the sample volumes that were available. So we categorized people into 3 groups. We used the cutoff of 1 based on the findings in the Framingham offspring. And then we wanted to look specifically at this group to see if there was any difference in these people with really low concentrations. Vitamin K is transported on triglyceride-rich lipoproteins, so there was a positive relationship between plasma vitamin K and triglycerides. And we also found a site difference. So the people in Memphis were less likely to have very low levels than the people in Pittsburgh. This was unexpected, but we adjusted for it in our analysis. So what we found is that the people with very low levels, below the limit of detection, were significantly more likely to have worsening of cartilage damage and meniscus damage. The meniscus is actually made of cartilage, so this might suggest a role for vitamin K in cartilage. We saw some non-significant trends for those with very low levels in terms of osteophyte progression and bone loss, but like I said, they were not statistically significant. So the next thing we were interested was, I mentioned that vitamin OA is a leading cause of lower extremity disability, and no one's ever really looked at the relationship between vitamin K status and lower extremity function as a consequence of NEOA. So we looked at it cross-sectionally. The health HABC participants are fairly well characterized for lower extremity function. They all do what's called a short physical performance battery, which is a composite score that assesses your ability to get up out of a chair, balance, and also walk. And it's a 0 to 12 range. Those that had higher, above the 1 threshold, were significant, had better SPBB scores. They had faster gait speed. We didn't detect any difference with the 400-meter walk speed. This lower number here reflects there were some people that weren't able to complete it. The clinical relevance of these differences is uncertain at this point. Depending on what you read, the clinically meaningful difference in SPBB is between 0.3 and 0.5. In gait speed, it's between 0.03 and 0.05, so we're right on the edge there, and this definitely is something that needs to be looked at further. We also looked at the relationship between vitamin K status and change in function over time. So what we found was what those that were above 1 had better, this is gait speed, and they maintained it. There was a significant decrease over time, as there were in all the groups, but those with the sufficient levels had better at baseline and 4 years later. So what did we learn? We learned that the older adults, now don't forget this is a generally healthy group, with very low plasma phyloquinone were more likely to they had worsening of cartilage damage and meniscus damage, and that those that had the higher levels had better function at baseline and follow-up, but there was no effect of vitamin K or relationship between vitamin K and the rate of decline. So the limitations, we measured plasma vitamin K from one time point. The health HABC participants are older and fairly healthy, so the generalizability is limited, and the clinical relevance needs to be understood. So as part of my K award, I've kind of taken a translational approach to this question of vitamin K and osteoarthritis. And when I was at Wake Forest, we did an animal study. There have been no studies that have looked at the relationship between if an intervention of dietary vitamin K affects NEOA. So we did an animal study to determine the effect of a low vitamin K diet on OA progression in rats with surgically induced NEOA. So what we did, we had 20 rats. They were all male, 3 months old, and I'm not going to say we, a collaborator who was at Wake at the time, who is now, I think he's at University of Missouri, Mike Callahan, who is a very talented microsurgeon. We did a surgical procedure, and I'll show you what it is in the next slide. It's called the DMM, or destabilization of the medial meniscus, on their left knee. And then between 4 and 7 days later, we randomized them to either receive a low vitamin K diet or a control diet. They were on the diet for 10 weeks, and then we sacked them, and we harvested their knees and other tissues. So what is the DMM? So what it involves is opening up the joint capsule and basically snipping the medial meniscal tibial ligament. And what ends up happening is the meniscus then kind of flops around, and that causes cartilage to either wear away or become damaged, and it leads to OA. So how this is scored is it's a semi-quantitative scale of 0 to 12. After you take the knees, you section them and stain them. The left is H&E stain, and the right is saffron and O. So the left, you're looking, the H&E stains more for the structural integrity of the cartilage, and the proteoglycan kind of stains for the substance of cartilage. But you can see normal here, which would be like a score of 0. The left, the cartilage is nice and smooth, and in the saffron and O, there's nice red staining on the surface. As you get more OA, you start to lose the red staining, and you start to see clefts in the cartilage. And when you have severe OA, there's almost no staining here on the surface of the cartilage, and you see lots of clefts. So this would be a score of probably 11 or 12. So let me see what we have here. So we sent the knees to a collaborator in the University of Minnesota who was blind to the intervention, so she didn't know what knee she was scoring. She actually is, her name's Kathleen Carlson, developed the scoring system. And this is, I'm going to use the saffron and O grade staining as an example. You can see the rats on the low vitamin K diet had consistently higher scores, which reflect more proteoglycan loss from the cartilage. We had huge variability in the control group. So statistically, there was no difference. I want to point out that this surgical model was more commonly used in mice than it had been in rats. But at the time we did this experiment, we had more knowledge of vitamin K insufficiency in rats than mice. So we adapted the surgical model to rats, but we really learned a lot about the variability. So what did we learn? That low vitamin K or vitamin K deficiency didn't affect knee OA in rats after the DMM surgery. As I said, to the best of our knowledge, it was the first time used in rats, at least it had not been published, and there was huge inter-rat variability. The other thing is that surgical models mimic traumatic OA, and in terms of translating that into the human condition, it might not be as translatable as an aging model. The mice and rats will develop OA with age. So that is one thing we're going to try to do, is repeat the study using an aging model. And we're also going to use mice because now we have a better handle on vitamin K deficiency in mice. You can't make them too deficient because then they bleed. And we also plan to expand the epidemiology to a larger cohort focused on OA. So is there a role for nutrition in OA? I would say weight loss and exercise, yes, but that's not usually the easy fix. Micronutrients or single nutrients, potentially. I think that different nutrients might be more relevant to different tissues within the joint. It might be a complement to weight loss, and I think it's something that needs to be studied further. And I'd just like to thank mentors, co-investigators, collaborators, and funding. Thanks.
So thank you very much, Kyla. We've got a lot of technical questions. Alice.
So Kyla, that was really interesting. I was struck by that cartoon you showed at the beginning about what the joints actually look like, and then sort of the hopeful results in terms of diet and exercise. But does that suggest that there can actually be repair of that joint once the cartilage is lost?
I don't think it, to the best of my knowledge, I don't think it can be repaired. I think the best you can do is to stop it from getting worse.
So then how did it get better? I mean, what you showed right after that is that it actually improved.
Oh, that here?
Yeah.
So this is function here. This is function. So this was not, this study also looked at, they did look at some structural outcomes in x-rays, and they didn't see any change in the structure. So this was independent, like regardless of where they were in terms of their structural changes, they noticed they had improved function. Which,
Well, I guess that's encouraging.
yeah.
But does that mean that then the function was better because maybe impact the muscle?
Oh, absolutely. It could be. It probably was.
Actually, with weight loss, the loading characteristics on the joint change so that normally with OA it's imbalanced and then maybe actually become more balanced with weight loss. The other thing that is very difficult to measure in a live human being is the interarticular level of inflammation, which is correlated with symptoms of illness.
So I want to ask Alice's question, I think, in another way. That is there any turnover of those meniscus proteins, the glycogen via collagen, or any of the proteins that line those joints?
To the best of my,
Because with that
yeah.
information, you'll be able to predict, I think, what the inflammation might be.
So to the best of my knowledge, it doesn't regenerate. It's not a regenerative tissue, which is why I think they're looking more towards interventions that can delay the progression, not necessarily reverse it.
Right, so you mentioned the weight loss and the exercise, but I think because it's a tire wear problem, so what type of exercise may matter a lot? Because some exercise may worsen, may be harmful. Could you comment on
So the study, and actually there was one that followed it, it was 30 minutes of walking. And I think if there were people that couldn't do the 30 minutes of walking, they were allowed to do an exercise bike. And it was clinic-based if they wanted it to be clinic-based, but they were also allowed to do it on their own if they wanted to. So it wasn't high-impact exercise.
So I'm going to prove that I'm awake during my commute, at least when I'm driving. So vitamin K seems to be a really good measure of a healthy diet. So for the studies that, at least the epidemiologic studies, you control for just about everything you could control for. What's your level of comfort that the findings aren't due to residual confinement?
They very well could be. I mean, I think we did the best we could. We had lots of measures in Health ABC, and we looked at controlling for different dietary factors, and we ended up, I think here I use a healthy eating index, but we looked at vegetable intake, fruit intake, and controlling for different indicators of a healthy diet, and the results were similar. That being said, I can't discount residual confounding.
Yeah, well, that was one of my thoughts also. And people that tend to eat more fruits and vegetables and fish and don't smoke tend also to be more physically active. So it's really tough, and it's nice to see that you're making the transition to the animal model where you can control for a number of those factors.
Any other questions?
So,
There's one more.
so I guess you're still trying to pilot the rat assay in terms of it hasn't really been done before. How did you pick the particular strain of rat that you're using, and if you look to see if other strains of rat may have less variability in terms of their kind of baseline osteoarthritis?
That's definitely possible. I was kind of relying on the expertise, I shouldn't say we, of the collaborators at Wake who had experience with animal models in OA. It was a tough call, but there had been studies that have used Sprague Dawley rats before and didn't look at nutritional factors, but at some potential therapeutics, so that's why we picked it. Hindsight, it wasn't the best model, but there's no evidence that we know of that other models have other strains have different variability.
What about within mice?
So there's still variability within mice. I don't think, we didn't know what the variability in rats was. To the best of my knowledge, there's less variability in mice. With this surgical procedure, it's actually easier to do in mice. It's easier to get at that meniscus to cut it, whereas in rats you kind of have to go a little bit deeper into the joint, which could affect the variability. But But I think there's variability with all animal models, and part of it is maybe increasing the number of animals that we use.